afternoon. Good afternoon, respected judges and all dear delegates. Today I am going to present a case study on bilateral diabetic retinopathy with vitreous hemorrhage, neovascular glaucoma and partial vitreous detachment. It was also an old case of central retinal vein occlusion right eye and cystoid macular edema of the left eye. There has been no financial support and sponsorship for this case study. So as we all know, diabetic retinopathy is a condition of the retina caused by microangiopathy due to the long-term effect of chronic hyperglycemia. And this leads to the swelling of the retinal layers. So this was a case history of a 42-year-old female patient who reported to us at the OPD with diminished vision in both eyes, right eye more than the left eye since 3 years, which was gradual in onset and progressive in nature. And there is also associated mild constant dull aching pain in the right eye since 1 week. And she has also been complaining of wandering blackish spots on looking around in her right eye since 1 year. She is a known case of diabetes mellitus with hypertension. And she gave a previous history of diminution of her vision in right eye 4 years back when she was diagnosed with CRVO, and her vision had deteriorated to hand movement positive. She had already taken 2 doses of injection ranibizumab back then, 1 in either eye. So the present visual acuity of the patient was, in her right eye it was PL positive and PR positive, and the intraocular pressure was 66 millimeter of mercury in her right eye. On applanation tonometry it was 52 millimeter of mercury, and on gonioscopy in the right eye, neovascularization of the angle was also seen. The conjunctiva was congested on slit lamp examination. The iris of the right eye had neovascularization at the pupillary border. The pupil was sluggishly reacting to light and mid-dilated, and the anterior chamber was shallow with a 0.5 mm hyphema seen. The rest findings of the left eye were within normal limits. So this was the picture of the right eye with the hyphema and the mid-dilated pupil with neovascularization of the iris, and the left eye was relatively normal. On IDO examination, we found that the right eye, the media was hazy due to vitreous hemorrhage, and fibrous band was noted superonasal to the disc. A macular preretinal bleed was seen and hemorrhage in the vitreous cavity. The retinal vessels could not be visualized properly. On the other hand, in the left eye, the media was clear with multiple dot blot hemorrhages in all quadrants and hard exudates. So this was the picture of the left eye, the fundus photograph of the left eye. Left eye. This was the left eye. Oh, yes, sir. And this was the picture of the right eye. Ma'am, right eye had developed CRVO 4 years back. The right eye. This was the left eye. The picture. Yes, sir. Yes, sir. So this was the picture of the OCT picture of the right eye and the left eye. And an ultrasound B scan was done, which showed mild vitreous hemorrhage with posterior vitreous detachment. So we started the patient on anti-glaucoma medications, Dozox-T and Bidinellis with tablet Diamox, and steroids were started with topine, and injection anti-VEGF has been given. Follow-up is being done for the patient, and the patient has been counseled for surgery. So the discussion, rubeosized iridis is the neovascularization of the iris, as we know, with numerous coarse and irregular vessels on the surface and stroma of the iris. Many studies have already been done on PVD in neovascular glaucoma and proliferative diabetic retinopathy. And we have concentrated mainly on this case in reducing the IOP and pain of the patient, and then planned for intravitreal anti-VEGF injections for reducing the neovascularization. So on conclusion, cases like this should remind us that diabetes and CRVO, once diagnosed, should be managed carefully with timely follow-up. As she had not visited us when she had been diagnosed with CRVO, so we do not know much of the details earlier, but this was the present picture when she came to us in the OPD, and any rise in the IOP should be strictly controlled. These were my references. Thank you.
Doctor, you told that your right eye was having a vision of PLPR,
Yes,
and the pressure was 66,
yes, sir.
something like that. So the picture what you showed that doesn't relate to that vision, number one. And what was the, for what patient came to you?
The diminution of vision. She also had
Anything relating to pain or something like that?
pain was there
in
since
right eye.
mild
So
dull.
what did you do for right eye?
So we started here. She had already discontinued all the medications before. She was treated before she took injections, but then she discontinued the medications.
Do you think that any injection will help the patient at the pressure of 70? So what would you do in such cases?
Sir,
Is anybody, your senior is here? Anybody who, you're a PG student, right?
yes.
So anybody who's ophthalmologist with you here so that we can discuss the case with them? No, okay. So apart from the questions he asked, what is very important in NVG is to know whether it's a closed angle or open angle, which you did not mention.
Yes.
Because that changes the treatment. If it's already a closed angle neovascular glaucoma, you will of course give injection with a paracentesis and then proceed with surgery. See, ultimately the treatment for NVG is what? What is the treatment? What is the treatment for NVG?
Anti-VEGF.
No, anti-VEGF is only temporary. It will last for 2 weeks, 3 weeks. Treatment is laser. Only laser, laser, laser and laser. And in addition, you may do an anterior retinal cryo. Now, when you already have vitreous hemorrhage, pressure is 66, laser will not go. So now your idea becomes, I have to operate, I have to remove this blood, I have to do laser during surgery as much as I can, and wherever I can not do the laser, I will do anterior retinal cryo. That is your idea. So towards that, you may give an anti-VEGF so that the new vessels may regress in the first 1 week, and then you can operate safely. You can do that. But you'll have to do a paracentesis at the time of anti-VEGF, otherwise you can't even inject. Now, if you have not even seen whether the angle is closed or open in the first few visits, you have to have an idea. If it's open angle, then just your laser and ARC will be enough. The angle will be enough to take care of the drainage because you would have taken care of the ischemia. But if the angle is already majorly closed, more than 50%, then you know that despite you treating with laser and ARC, patient will still need a glaucoma filtering surgery, for sure.
Yes,
So then you counsel accordingly, you plan accordingly, you do your surgery, you do a vitrectomy, do your laser, but you're mentally prepared that pressure will not come down because angle is already closed. And then you are ready to refer them for a shunt surgery. Sometimes it's not possible to even, if it's not possible to do anything, you can't even see, then you give an injection, anti-VEGF, get the new vessels down, get a glaucoma filtering surgery done in the next 2 weeks when there are no new vessels, and then proceed with laser. Once the cornea clears, and if there is no vitreous hemorrhage, proceed with laser. But knowing whether the angle is open or not is very important.
So your case was good, but your message is not clear.
I have one question. So patient also had cataract. So at what stage would you do the cataract surgery?
At this point, once the new vessels go, see, anti-VEGF has to be given to move next step. Once you've done that, you can even handle the cataract if you feel that that is going to obstruct your laser treatment or the vitrectomy. But if you feel it's not obstructing your current treatment, then it could wait. But once the new vessels have gone with an anti-VEGF, you can do cataract surgery as well. If you can do a glaucoma filtering surgery, you can do a cataract as well. Anybody in the audience has any query about NVG or diabetic retinopathy?